Well, who's at risk? These people. Anybody who's been in shock for any reason whatsoever. Remember, cardiac syncope is shock. Sepsis is a very popular pathway into it. Watch these septic patients. Trauma, the more bones you break, the more likely. It's a way of quantifying your trauma. Folks with lung contusions, that's people with seatbelt abrasions across their chest, people who've been kicked in their chest, people who had CPR done to them also. Anybody with a diffuse infectious pneumonia. Pneumonias are not diffuse. They tend to be nicely localized, and if you've spread it throughout both your lungs, you got it worse than anybody else does. If you aspirate and don't get ARDS, you can get aspiration pneumonitis and dissolve your own lung tissue, which is no fun either. Having been put on heart-lung bypass is in itself a risk factor. Your body never intended to have its blood sucked out of it in a plastic tube and put back in again. It can consider that an injury. It's an offer response to injury, which is why we're trying to do as many open hearts now off pump as possible. Now, they're doing them on beating hearts. If you want to know how in the world you can operate those little tiny scissors and those little tiny needles on a beating heart, YouTube has a fabulous medical section, and you will see how to do it. You know, when you think about YouTube, I don't know about you, you're younger than me, but I always thought, frivolous. But no, there's some fabulous stuff in the medical section, and you can see exactly how you go about working on a beating heart. Surface burns, the bigger the burn, the more likely. If you survived your drowning episode and now have respiratory distress, it's ARDS. This is the way oxygen toxicity kills. Folks with pancreatitis, because it is an itis. What does itis mean? Any disease ending in itis, you spread it throughout your entire body, you got SIRS. I had a patient who did it with myocarditis one time. The deal with folks with pancreatitis is that they're so incredibly sick to start with. It's very easy to tip right over. Anybody with DIC, because there's your hematological component. Pregnant people are prone to DIC. Cancer patients are very prone to DIC. Anybody with a fat embolus. This is who's at risk to go into ARDS. That take care of a big chunk of your patients? All right, early detection, what does it look like? Oh, well, first we have to say what happens. You get the initial insult, which is the previous slide. You set off the response to injury, and the response to injury is inflammation. Out comes the mediators, the capillaries dilate, the fluid pours out, and the pores are stuck open. Your causative problem is these pores are stuck open. We have never come up with a drug that would close them back again. Everything we do for these patients is supportive care. And you know what the supportive care entails? Oxygenation, perfusion, and nutrition. Same thing it does anywhere else. It just gets a lot more complicated when you move it into the unit. Okay, now we say, what does it look like? Well, if you see these folks gliding down the hall, follow them, okay? They're going to take you to your ARDS patient. The clinical picture of ARDS is, it is a severe acute onset of life-threatening hypoxia that oxygen does not make better. Now the first part here is severe acute onset, but it's not like blowing a pneumothorax or throwing a PE, which is a sudden event. This one, from the time it starts to the time you're going to have your hypoxic code, only a couple of hours transpires. So if it's 3 in the morning and you're going, you know, that doc will be here at 7. No, you don't have that kind of time, all right? It is a life-threatening hypoxia. ARDS, like everything else, appears on a continuum. You can have so little of it, we just give you a little oxygen, you get better. You got so much of it, you die a horrible death on a ventilator in a unit somewhere. But let's kind of go to the middle, okay? Life-threatening hypoxia that oxygen does not make better. And here's your first big clue that what you're looking at is probably ARDS and not something else, and that it is refractory to oxygen therapy. I'll show you why in a little bit. If you ever put oxygen on your patient and you don't see their O2 sat or PO2, whichever one you're looking at, respond to that oxygen, go straight to 100%. Because the deal with ARDS is that oxygen will not make it better. And you want to know that now, not after your patient has a hypoxic code, because you've been slowly dinking your way up on the oxygen, all right? All right, first big sign, oxygen doesn't make it better. Second big sign, breath sounds. You got a patient with a life-threatening hypoxia. You know, when you put your stethoscope on that patient's chest, you'd expect to hear horrible things in there, wouldn't you? Like an absence of breath sounds because he's collapsed both of his lungs, or uneven sounds, or just god-awful nasty stuff in there. And you know what? Breath sounds are unremarkable. They are not clear. They are unremarkable for a life-threatening hypoxia. You hear them all the way down both sides. Coarse is a really good descriptive word, what you hear. Maybe a crackle over here, maybe a wheeze or two over there, but nothing that would account for a life-threatening hypoxia. And let's take a look at why.